So now I'd like to welcome Dr. Huzaifa Adamali, who's going to be talking about factoring patients' beliefs and values into decisions around anticoagulation. It's a community-led multi-cycle quality improvement project. And Dr. Adamali is co-lead of Bristol Interstitial Lung Disease Service in North Bristol Trust, where he is involved in diagnosing and managing interstitial lung disease. Dr. Adamali wears multiple hats as a clinician, researcher, and lecturer of medicine. His passion lies in addressing health inequalities, and he supports this endeavour through his work at North Bristol Trust and the Black Asian Minority Ethnic Network. So welcome to you, Dr. Adamali.
Oh, thank you so much. I wonder if you can hear me all right.
Yes.
Fantastic. I'm using a handheld phone and I'm using a screen there. My laptop, I'm sorry, my desktop hasn't worked with the sound, so I do apologize if there is any feedback. So thank you so much, Andrea, for inviting me, and to Joe for having me here today. At the offset, I think this project that I'm about to talk to you about is amazing because it involved many bits of our organization coming together to address patients' beliefs and decisions into anticoagulation. It was funded by the Southmead charity, and I'll explain to you how it's got funded by our charity group. I work at North Bristol Trust. As Andrea says, I wear many hats, but one of them, what I'm really passionate about, is health inequalities, and this project reeks of it. So the people should know that, sorry, I'm just trying to get my next slide on. Come on. Yes. We have a lot of religious and cultural and lifestyle beliefs to guide people in their dietary decisions and behaviors, I guess. You go into a restaurant, you will look at menu cards, allergies. I, as a Muslim doctor and practicing Muslim, will go in there and make sure that there's no pork, fish products, certain things I don't eat. And I guess we as healthcare physicians have to be very mindful of individuals and respect their decisions about their dietary beliefs or religious beliefs. And most of the common religions in the UK, including Judaism, Islam, Hinduism, Sikhism, have followers refusing to ingest certain animal products. And an increasing group of individuals are becoming vegans and vegetarians. So we have to be aware of that and very receptive. So we know that NICE recommends venous embolism risk assessment in all our patients, and many of our patients will end up on low molecular weight heparin. And it's known that enoxaparin and unfractionated heparin are commonly prescribed as first line for the prophylaxis and treatment for VTE for patients. But it's not commonly known that both these products are derived from porcine animal products. And there is a synthetic alternative, which is fondaparinone, and it can be used as a replacement in most clinical scenarios. However, the problem is this option is not readily discussed with patients in our hospitals. And of course, when you are in the UK, you make certain assumptions. You have unconscious bias playing. And if you have a white patient, you automatically assume that he's Christian or it's acceptable for them to have pork. But they could be vegetarians or vegans. And it is important that we discuss this with our patients before prescribing medication. Now, I'm not talking about only low molecular weight heparin, it should be all medications. But do we know what the contents of our products? The NICE guidance, the NG89, does say, unequivocally, be aware that heparins are of animal origin, and this may be a concern to some people. discuss the alternatives with people who have concerns about using animal products after discussing their suitability, advantages and disadvantages with the person. So it's out there. Now, one of the things that we as an organization and many organizations within the NHS are very poor at is documenting people's preference. But interestingly, ethnicity is never documented very clearly, and diets are not equally documented. However, it should be routinely documented in the information that we are provided with. But interestingly, and I'll come to this, is patients do declare this to their general practitioners. Is that information shared with you, especially the F1s, F2s who are floating at night, or the MU doctors who are admitting, or emergency doctors who are admitting? Are they actually looking at this carefully? Now, the work that I'm about to present generated from a complaint from a Muslim patient who had received enoxaparin without being consented for it. And there was a Datex alert that was generated, and they came to me to ask me, what are they going to do about this? So I have a fantastic colleague by the name of Dr. Shani Barrett, who's my white ally. She understands me very well, and she understands all the difficulties that individuals from people of Black, Asian, minority, ethnic origins suffer from, because we've been working together for almost 12 to 13 years. We decided to do an audit, and this audit...
Can I just ask, there's some people in the audience who are saying they can't see your slides.
Oh, they can't?
No,
okay.
I'm not. Can people just in the chat just put in if you can see the slides? About 3 people are saying they can't. They seem to be dragged off. I can see them. Yeah, they can see them now. That's fine. That's fine.
Okay, I'm really sorry about that. I do apologize.
No problem.
So Shishani and I decided to do an audit, and we had some wonderful doctors, Dr. Fraser Easton and Alec Weston, who were working with us. And we wanted to know, and this was during the COVID-19 pandemic, if individuals were consented for low molecular weight heparin with that knowledge that they were porcine content. Now, the problem we faced immediately is, where are these patients? Because the ethnicity data is not readily recorded. So what Fraser and Alex did cleverly is they looked at halal meals, and they went backwards and documented where who had these halal meals, and they worked out those patients that received this medication, because you automatically assume that halal meals will be had by Muslims and so on. Interestingly, I've been told halal meals taste better in certain organizations, and they are ordered by other individuals also. And what we found was this audit highlighted that there was religious beliefs were not routinely documented on most hospital admissions, about 95%. Healthcare professionals, 95%, did not routinely consider religious or non-religious beliefs when prescribing medication. Of the prescribers, 23% were unaware of the porcine content of enoxaparin, and there was poor prescriber awareness of the non-porcine alternatives that were available. And that was about 43% were aware. So this was worrying, I guess. So what did we do? So we decided to hold community group sessions, and we decided to consult local community groups, faith groups, where the consumption of animal products is against religious beliefs. We looked at other individuals' groups, including the vegetarian and vegan societies. And we had lots of other individuals who attended these groups. And what did they tell us? And they told us, why don't they tell us? Don't the pharma companies have to make it clear? But all this type of information is put on menus and food labels, why not on drugs? They said, lots of doctors don't say what it is when they see the doctor like to take advantage. That's what it feels like. It is like we get stuff done to us without asking. we don't have a chance to have a choice or to say no, just because they assume they know what's best. Then they said we shouldn't have to give out clues. If I get a clinician who doesn't assume something about me and asks me, it instills me with enormous confidence. It's all about mental and moral well-being. How should the information be provided? Are you telling us that hospitals doesn't have access to our GP records? My GP knows all this stuff about my dietary preference. So why aren't the vegetarian versions the ones used as standards? If they don't work as well, then isn't that when the doctor should talk to us about it and what the different options are? And they said, the challenge is when do you have the conversation in emergency? But if it's an emergency when the information needs to be available in a range of different ways, but I guess a video in multiple languages might be best. Then you can have subtitles. So they were telling us lots of information that was going to be useful for our project that we're going to develop. And who should provide the information? Obviously, the doctor needs to prescribe the drugs, but if everyone knows about the issue, then if I tell a nurse, she would know to tell the doctor. Does it actually work that way? It sounds like a lot of change needs to happen in the hospital for everyone to know about heparins not being suitable for Muslims. Doesn't that mean a policy needs to change? And when should the information be provided? And they said, if it's life-saving or an emergency, then I can understand doctors not asking, but they should raise it as soon as stuff has settled down. So what we found from this consultation, and we did quite an extensive consultation for several weeks, that current practice of low molecular weight prescribing is unacceptable for patients. They require greater knowledge and transparency regarding product components. And it might be time for medical labeling to be changed to provide this level of detail. So we then put a project together, and it was subsequently published. And this has to be said, it was funded by Southmead Charity. But what Southmead Charity did was they had lots of money and they wanted good projects to be funded. So myself, Shani Barrett, went there and presented this work, and we got funding for about £50,000. There was to lead a project in looking at this. So what did we do? We decided that we needed to improve the patient choice and prescription of heparin, and we used smart guidelines. For 90% of patients admitted to AMU who are prescribed low molecular weight heparin to have a discussion about their values, beliefs, and preferences in regard to the most suitable heparin prescription. We decided to do 90% because we expected someone too sick, didn't have capacity, language barriers may be a problem, and so on. The primary drivers for this project were awareness, information on options, staff guidance, and conversations about preferences. And the secondary drivers, which requires clarity, expertise, and behavioral changes. That was with knowledge, confidence, and time. So how did we decide to empower or in kind of make sure that we got all these parameters covered? So we decided to do staff communication, which I'll talk about in a minute, patient videos, patient information leaflets, a robust switching policy, dedicated pharmacist time to support this project. And also we designed, and we talk about staff training, I was hearing it. We did a 5-minute staff training learn module, which was easy to complete and which empowered individuals to know about this and how to consent patients. And this was this is the learning module we did. And we targeted doctors working in the AMU, and it was completed in when we initially started, about 64 staff members, reflecting good uptake of the intervention. And we had a lot of mixed professionals doing this: nurses, doctors, healthcare assistants, and pharmacists. It's readily available, and the best You don't have to create it within your organization. I have to admit that this module was created by my good colleague Natalie, who was a registrar working with us in respiratory medicine. Now, Nixon Lung and Alison Staples, who are our fantastic pharmacists, created a low molecular heparin to fundoparin switching policy. And this sits in our intranet, and it's very easily accessible, and it's for all professionals to access it. So if they have or they want to switch to this respective drug, they can read it, and it's very easy to follow. And we would love to share this also with other organizations, so you don't have to reinvent the wheel. We got our colleagues to do videos for us. We did it in Sudanese, Arabic, Urdu, and Polish. And we had information leaflets that we created in the respective languages. And when the project was, so what we did was we loaded these videos on tablets. So the doctors just gave the tablet if people wanted to know more about the drug before they consented and wrote the medication. And this is what happened. Now, I want you to look at the right-hand side, and this there are two cycles. Cycle 1 is, and the days on the day 1 to day 10. This is where all happening in acute medical assessment unit, and we looked at the patient consented for low molecular weight heparin. Remember, our target was to get to about 90%. Our first cycle, when we introduced this, and that was through just pure education, encouraging doctors to do the training module, using the leaflets, all of that, we saw a little bit of a seesaw plot there. And you can see it going up and then dropping at day 4 and going up and then down. And I got a funny feeling is when Dr. Adamali hovered in AMU, people took heed and uptake went up. And there were other issues doctors complained about. They complained that they continuously forgot. And they had lots to do in the middle of the night, and consenting was a big issue. So what we decided to do was we introduced a little sticker, and this is on the left-hand side, and you can see that we have a written proforma for DVT assessment, and we asked them a reminder, please ask your patient if their religious or dietary beliefs may affect their choice of anticoagulation. Did they discuss it with the patient? Did the patient want fundoparin? And we literally encourage people to fill this, and we audited this. And what we noticed that when we introduced that, the uptake went up. By day 10, in the second cycle, it was maintained at around 90%, which was good. So a simple prompt like this can make a big difference. Now, we were very lucky because we had our colleague Hannah Bonet, Dr. Hannah Bonet, who was doing, she's an AMU physician, and she was doing IT transformation lead. She's a transformation lead. And what she did was they did a digital VTE assessment form in Careflow, which is, and she kindly put in a prompt, animal products, enoxaparin and UFH are derived from porcine products and may be inappropriate for some individuals based on their faiths or beliefs. And fundoparin is a synthetic anticoagulant that may be suitable for alternatives. So everyone who prescribes this reads that, and it's a trigger for consenting and making sure people's values and beliefs were considered. Fundoparin, yes, it's a medication that's readily available. It's not for everyone, I have to admit. There are individuals that you won't prescribe this, especially in renal patients, certain renal patients, and the neurosurgeons are not very keen on this because of the higher bleeding rates. But the thing is, majority of patients will consider this, and many physicians will want this available. Now, the thing is, we also did a patient survey, and when people were asked about this, and it was interesting what people said. I was happy it was discussed, and I could make the change. This is important for some people. I'm glad I was asked. I feel we must have choice. I'm against using animals for research and making medicine. It's important that we learn from the work. And they said, happy to be thought of, and them valuing my opinion, empowered to be able to make own decision about what medications to take. So it was really, it felt that our patients felt valued when we did this. And trust is key up in here. So conclusion, there are barriers to patients being adequately consented for low molecular weight heparin prescription. Simple measures can increase staff awareness and knowledge of porcine contact of low molecular weight heparin. It's important to consent patients before they're prescribed this drug. There is demand from patients for non-animal derived alternatives. Staff and patients reacted positively to this issue being discussed and with a significant positive impact on patients feeling respected and valued. And the current work supports the importance of considering patients' religious, dietary, and lifestyle beliefs before prescribing the medication. Not only low molecular weight heparin, but all different types of medications that may have animal products within them. So the team. Natalie Smith was our respiratory registrar, and she did the fantastic e-learning module. Leonie Williams was our quality safety improvement practitioner. Sam Harding is our health psychologist and research fellow. Kate Singh, the money also went to funding a manager. You need a good manager to run this project, and we were very lucky to have Kate. Duresh Somru was our IMT, who was very pivotal. Sugra Alawi was our Bahraini respiratory clinical fellow. Munira Chowdhury was our EDI lead. Verdip Durgan was our senior continuous improvement manager. We had a common assistant, Ellie Parker, within our organization, who was brilliant at disseminating information. Alec Hansen, Fraser assistants were junior doctors with us and now have become doing better things. Hannah Bonet is our AMU IT transformation lead. I put her name twice. I don't know why, but she's brilliant. And Nixon Lung and Alison Staples, our pharmacy colleagues, Seema Srivastav, who's our associate director and consultant for elderly physician. And finally, my fantastic white ally colleague, Shani Barrett, who just ran with this project and made it happen. So thank you. I'm very happy to answer any questions. And I would just like to thank for the listeners for listening. And I would like to suggest to my Nottingham colleagues who that they might want to include this type of work in their project with educating the students. Thank you so much.